Yes, sir. जोर से अपना नाम बताओ.
संदीप शर्मा सर.
The voice is clear. What all would you like to observe? This is the post-operative patient, the same patient that you were watching just now. So, Agni, what are the features you would like to check now? Clinically, the patient is here, it's fine.
So for the symptoms of signs and symptoms of hypocalcemia.
They won't happen immediately. No. First, of course, is the voice.
Voice and vitals.
What else?
So numbness or perioral numbness.
So that we won't see immediately. No, it has just been done. And can you summarize this case from the beginning to when we achieved the PTH and how we closed it?
So Mr. Sandeep Sharma.
You have to be louder, otherwise, or the phone has to go closer.
He's 46 years male. Mr.
It's the same
Sandeep.
patient that you have presented. Okay,
And 1.5 years, since the 1.5 years period, past 1.5 periods, he was complaining of generalized weakness with bone pains and weight loss, and also complaining of depression and anxiety since last 1.5 year. And patient notices swelling at the anterior aspect of at the front of his neck on the right side. He presented to us in the OPD with these features. On examination, we found out on the right side, we examined his neck, and we found out a large swelling in the right side of the neck, which was firm and mobile with deglutition, and the swelling was almost 3 centimeters in size. And
So how did you differentiate it from a thyroid swelling? Why was this not a thyroid swelling?
so we could not
Clinically.
differentiate it from
So we
the
did not know.
thyroid. That's
You understand that? So it moves on not deglutination, it moves on deglutition. Everybody says deglutination. Deglutition is a word. It moved on deglutition like any thyroid swelling also, but we couldn't differentiate. She's right. And finally it was on ultrasound that it was found out, or on some other method. How was he screened?
He was screened by his biochemistry panel. He presented to us with serum calcium levels which were high to the value of 16 milligrams per deciliter, along with his PTH values which were 2100 picograms per ml, and his vitamin D was low. Rest parameters, RFTs and LFTs, they were in the normal range. And after that, patient underwent a high resolution ultrasound which reported to us a swelling of 4 cross 3 centimeter cross 2 centimeter at the right parathyroid lobe, suggestive of an enlargement or adenoma of the right parathyroid. Later on, the patient, when after coming to us in the OPD, we sent him for his System-B scan, in which we found out a large right-sided parathyroid nodule, and along with parathyroid lesion, and along with that, he also underwent a choline PET scan, in which we came to know that it is a parathyroid swelling. Intraoperative findings, we found out that the thyroid lobe was separate from the right thyroid lobe was separate from the parathyroid lesion, and it was so big that it was pushing the thyroid medially. And the pre-incision, we sent the parathyroid values. They were
PTH value.
PTH values. They were 2400 picograms per deciliter. And after we removed the gland and we sent it for frozen, 10 minutes after the removal of the gland, we found out that the parathyroid levels had dropped to a tune of 240 picograms per deciliter.
Frozen was positive for adenoma. We wanted a carcinoma to be excluded. And like you mentioned in the pre-op discussion, we are suspecting it to be carcinoma on account of the size and the level of calcium and the PTH levels. But we did not find it adherent to the gland, that is thyroid. And there was an associated gland which probably came out with it. There was possibility of a lymph node also, but we finally got a report of adenoma only. For an adenoma, we also weighed it. How much was it? The patient this specimen was weighed in the pathology. It was 18 grams. And 18 grams is too large for any adenoma. Very surprising. So we had that doubt of carcinoma. But with the kind of reduction in the PTH and the outcome, I think he is more or less cured of it. which will make a lot of difference in his bony symptoms, his overall quality of life, and general outcome. Right? What do you feel about it now?
Feeling better, sir,
And happier.
after your arrival. Thank you so much, sir.
So, and importantly, for you, what is one take home? You're too young to have one take home, so you can have four. Rarity of the condition. Your take home, Agni has been speaking. So, your take home from this case. Why are we talking about it? What is so important?
Sir,
It can remain hidden. The symptoms may not manifest, and the patient may only know that he had a problem when the problem is gone. So this patient is suddenly liberated out of that, state. And, oh my God, I am so good,
Obviously.
and you suddenly feel I am recovering from a problem. Otherwise, he would have felt this is the way life is. होता नहीं है कि sometimes you live in darkness forever. You don't know what is light. It's only when light is shown you appreciate darkness and light both. Same thing happens here. Second thing is the bones will gain back some strength. I asked you in the discussion about brown tumors, pathological fractures, all those liabilities in a young patient. They make a big difference to his quality of life. So surgery is got to do with, there is no other treatment for this. So the right surgery. So while doing surgery, Agni, what are the precautions, or Ojas, what are the precautions? If you could put down into 1 to 5, you would like to take, which came up.
So precautions that were necessary here were to preserve the recurrent laryngeal nerve, the middle thyroid artery, the superior thyroid artery, and
There's no middle.
inferior thyroid artery, and should
so we have to preserve the planes properly. Trapezius muscle should go along with our flap so that the
That's about
flap
raising the
muscle-
flaps and the technique usually. The four take homes just. One is mentioned, recurrent laryngeal nerve. The other is
the parathyroid hormone,
parathyroid
parathyroid
and external laryngeal nerve
external.
and
inferior thyroid artery.
inferior thyroid
Branches only
artery,
should be like it.
only capsular branches if at all, and we should dissect in that triangle to make it happen. And secondly, when closing, you should make sure that when the patient is anything else, you were saying something? Before we close, what did we do? The wall selva maneuver.
Wall selva.
So no bleeding should happen, and hemostasis has to be perfectly done. And then, importantly, the voice. So when patient was extubated, the vocal cord checking was done. And the best test of that is the pitch of the voice and the timbre of the voice that you can hear now. So that is what the recovery is. We will be observing him for what now? Show me your face. Where is his face? Let's do it here. That's the mastoid process. The nerve comes out somewhere here, out of the foramen, and tapping it in front. See, some twitching may happen. ऐसे रखेंगे.
आप खुद से मत
अच्छा ठीक है.
चेक कर.
So that's an important point she just made. If you tap anybody here, that's why it's not a sensitive place. Crosby sign is more objective. Here your tap would matter, patient's response would matter, and it is therefore I was demonstrating how you can get it produced in anybody. You just tap it hard enough, the muscle will be excited into contract. But blood pressure there is a cation exchange. You must read that more. This is broad what you said. T sign will have ionic exchange, which is important. The T sign is a follow-up. So we are going to observe for hypocalcemia, and you should keep IV calcium ready, and calcium has to be given slowly over a period of 10 minutes. Or how much is the dosage that you give?
So we give 10 ml of 10% calcium gluconate, which we add in 10 ml
Give
of
it in 10 minutes.
NS.
So you can add it in 10 ml of saline and give it over 10 minutes. Getting the point? And if you give excessive calcium or if you give it quickly IV, what will happen? I have taught this.
So arrhythmias can happen in the patient.
You said the same that day, but then I told you something else. The heart stops in systole and potassium, heart stops in diastole.
Diastole.
This is not for you. This was somebody else, some other case. Okay? And now you relax. Huh?
I'm just listening only, sir.
Don't worry. Relax now. Try to put up, go to sleep. We'll shift your zone. And we'll observe you for a day for all those things that I was teaching them, which are pertaining to the calcium levels in your system. Now I was teaching them about the hungry bone syndrome, which means your bones now will claim the calcium. They were deprived of it for a long time.
Out of the blood, sir.
Out of the blood. So the level will drop. We'll keep a watch. It may not drop that much, but if it does, we have to replace it. Is that okay? Now you can give him sips of water. Sister, moisten his lips and he can have some sips of water. The incision closed and it will just be a straight line. You've seen the incision being closed.